Assalamu alaikum, good day everyone. This is Lam Al-Hidam from King Saud bin Abdulaziz University for Health Sciences, and today we'll be talking about breast cancer. Here's the outline of today's presentation. We will start off with introduction. So breast cancer is the most common cancer among females worldwide. It's the second leading cause of cancer death in the United States, United Kingdom and Canada, following lung cancer, and in Saudi Arabia following colorectal cancer. For women in Saudi Arabia between the age of 20 and 59, it's the single leading cause of cancer death. The incidence and mortality due to breast cancer has reached a plateau and decreased slightly in the United States and Western Europe. This is believed to be due to less prescription of hormone replacement therapy, early detection through the use of screening mammography, and the appropriate use of systemic adjuvant therapy. Here's an overview of the normal breast tissue showing fat tissue and fibrous breast tissue. Milk will originate in the lobules, travel through ducts, and exit in the nipple area. The upper outer quadrant has more breast tissue and therefore is more prone to breast cancer and more prone to breast pathologies in general. Now for risk factors. First of all, gender. Simply being a female carries higher risk of getting breast cancer. Male breast cancer happens, but it is rare. Stage for stage prognosis is similar, but male breast cancer is usually diagnosed at later stages, so generally male breast cancer has poorer prognosis. If you have male with breast cancer, consider genetic testing, especially for BRCA2 mutation. Age is the most important risk factor. As a person gets older, their chance of or the risk of getting breast cancer is getting higher and higher. The median age of diagnosis is in the United States is 61, whereas it's 49 in Saudi Arabia. Having first-degree relative with breast cancer is a risk factor for breast cancer. The risk increased even more if the relative was diagnosed before the age of 30. BRCA1, BRCA2, and P53 are the main genes involved in or associated with breast cancer. We will talk about them in details later. Now for Knutson's two-hit hypothesis or multiple hit hypothesis, it states that in general for cancer to occur, you must have two inactivated tumor suppressor genes. This explains the age difference between the difference in the age of diagnosis between people with inherited inactivated tumor suppressor genes, such as people with BRCA1 and BRCA2 mutation, and people who acquired both inactivated tumor suppressor gene environmentally. Here are the genes strongly associated with breast cancer. They are all autosomal dominant, and they are all tumor suppressor genes except for CHEK2, which is cell cycle checkpoint kinase. We will talk about the first three in detail. So now we will talk in general quickly about P10 mutation, which is a tumor suppressor gene. Mutation on it is associated with Cowden disease or multiple hamartoma syndrome. As the name implies, you will have multiple hamartoma and increased risk of certain cancers, one of which, of course, is breast cancer. CHEK2 is cell cycle checkpoint kinase. It does recognize and repair DNA damage. It activates BRCA1 and P53 by phosphorylation. So mutation in this gene will be associated with increased risk of breast cancer. Now for BRCA mutations, BRCA1 in chromosome 17 could be inactivated, more common in more than 50% of some subtypes, or mutated rarely. It's strongly associated with ovarian cancer, poorly differentiated type of cancer, and triple negative or basal-like cancer, and usually cancer. The BRCA1 mutation cancer will have P53 mutation. It has very poor prognosis. BRCA2 mutation, we can in chromosome 13 we can have mutation or loss of expression. It's highly associated with male breast cancer. BRCA1 is associated with male breast cancer, but BRCA2 is highly associated. P53 mutation in chromosome 17, we can have loss of heterozygosity or germline mutation. It's seen in many tumors, the mutation. If you have if you have p53 mutation, you can have what's called Lefer-Mani syndrome, which is associated with many type of cancer. For breast cancer, it's associated with most frequent in triple negative type of cancer, and it's the most commonly mutated gene in sporadic breast cancer. Now, breast pathologies in general are risk factor for breast cancer, like fibrotic changes, previous breast lesion, and higher breast density. Now, for fibrolytic changes, we can have a collection of benign breast tissue with non-proliferative or proliferative changes. One of the fibrolytic changes is atypical hyperplasia. Atypical hyperplasia increases the risk of getting breast cancer by fourfold. Prolonged estrogen exposure. We can have it due to early menarche or late menopause, nulliparity or late first pregnancy, postmenopausal obesity, because as we know, we have the enzyme aromatase, which will be converted into estradiol or estrogen. And of course, we have exogenous estrogen, like hormonal replacement therapy or oral contraceptive pills. Please bear in mind that oral contraceptive pills' role in getting breast cancer is controversial. Radiation is a risk factor for breast cancer. So exposure to ionizing radiation during adolescence, after the age of 30, the risk does not change. So, for example, if you have a girl in having Hodgkin's disease, then treated with mantle radiation, her risk of getting breast cancer later in life will be increasing. Protective factors include breastfeeding, active lifestyle, soy and soy milk, and early menopause and early childbirth. Now we will talk about types and pathophysiology. First of all, we will talk about molecular mechanism of carcinogenesis. We can have it estrogen receptor positive or progesterone receptor positive, or HER2 new or human epidermal growth factor receptor 2 positive. Interesting factors, subtypes. Some of the subtypes, we can have it luminal A, which has the best prognosis or better prognosis, which is estrogen receptor positive, progesterone receptor positive, and HER2 negative. Luminal B has somehow worse prognosis. Estrogen receptor will be positive, progesterone receptor will be positive, and HER2 receptor will be positive. Basal-like is triple negative kind of cancer. We have all of receptors positive, not expressed, and HER2 positive, we have estrogen receptor negative, progesterone receptor negative, and HER2 positive. As we said here, we can have estrogen receptor positive pathway or estrogen receptor negative pathway. If we have HER2 negative, we will call it luminal A, again best prognosis. If we have it HER2 positive, we will call it luminal B, somehow worse prognosis. We can have it estrogen receptor negative pathway. If HER2 was positive, we will call it HER2 positive type of cancer. If HER2 was negative or triple negative type of cancer, or what we call basal-like cancer. Now we can see here types of breast cancer. It could be lobular carcinoma. If it was confined to the lobule and not invading the basement membrane, we will call it lobular carcinoma in situ. If it did invade the basement membrane, we will call it invasive lobular carcinoma. For ductal breast cancer, it's which is more common. We can have it either confined to the duct. We will call it ductal carcinoma in situ, or invading the basement membrane, and we will call it invasive ductal carcinoma. We can have Paget disease of the nipple, which is a form of ductal carcinoma in situ that extends into the skin over the nipple and the areola, manifesting with skin changes or skin lesions and exudates over the nipple and areola. Now, for types based on the histology, we can have it pre-invasive or invasive type of cancer. Pre-invasive will be detected only by mammography. It's not palpable, and it does not invade the basement membrane. For pre-invasive, we can have ductal carcinoma in situ, and one subtype is Paget disease of the nipple, or lobular carcinoma in situ. Bear in mind that Paget disease of the nipple may progress into invasive ductal carcinoma, so in some references you may see it as invasive type of cancer. Ductal carcinoma in situ is confined to the breast duct, detected only by mammography, and invasive carcinoma may develop over time. Usually 1/3 will develop into invasive ductal carcinoma. Paget disease of the nipple is a form of, as we said, ductal carcinoma in situ. We'll talk about signs later. For lobular carcinoma in situ, it's rarely visualized with mammography, usually detected incidentally by biopsy, and that's because it does not form microcalcification, so mammography does not pick it. Usually it's multifocal and bilateral, and for that you're advised, if you have lobular carcinoma in situ or invasive lobular carcinoma in general, lobular carcinoma, to do mirroring biopsy. So if you have it in the inner upper quadrant, you will do it in the inner upper quadrant of the other breast. Invasive the carcinoma may develop over time. Usually, again, 1/3 will develop into invasive invasive lobular carcinoma in any of the breast. For invasive ductal carcinoma, we have some subtypes such as mucinous or colloid carcinoma, which is cancer cells floating in mucin. Tubular carcinoma, which is a low-grade tumor, meaning it does behave and look like normal tissue. Medullary carcinoma, which is a rare high-grade type of cancer. Finger-like papillary carcinoma is a finger-like projections, very rare, seen in postmenopausal women. Cribriform carcinoma is also a low-grade kind of tumor. Invasive ductal carcinoma accounts for 80% of breast cancer. It originates from ductal epithelium and infiltrates supporting stroma. We can see here basement membrane, and here cancer cell going out of the basement membrane. Invasive lobular carcinoma accounts for 10 to 15% of breast cancers, originates from lobular carcinoma or lobular epithelium, commonly bilateral, does not form microcalcification, and therefore is hard to be visualized in mammography, and usually it may benefit from MRI or again discovered through incidental, if not palpable, discovered through incident biopsy. Here's an MRI picture. Inflammatory carcinoma is a ductal carcinoma that invaded the dermal lymphatics. It's the most aggressive form of breast cancer. We will talk about signs of it later, but we can emphasize on the fact that peau d'orange or peau d'orange or orange peel, translating literally into orange peel, is a sign that indicates very advanced stage of the disease. Inflammatory carcinoma can be mistaken for acute mastitis. Now for presentation, we can have asymmetry of the breast. We can have redness, discharge. Bear in mind that milky discharge is usually benign, while blood discharge is something you need to worry about. Lymph node swelling in the axillary lymph node or subclavicular lymph node here. Lump and dimpling of the skin. Peau d'orange, which is fixed opening of the sweat glands following lymphedema, because sweat glands cannot expand. We will see a picture of that later. Inverted nipple or retracted nipple, and constant pain. Bear in mind that usually breast lump are non-painful. Lump will be solitary, painless, and fixed to the chest wall. Other signs include axillary lump, dilated vein, and signs of metastasis, of course. Here's a good picture of breast cancer. We can see a carcinoma of the right breast. We can see elevation of the breast, dimpling of the skin, over here, and we can see retraction of the nipple. Here's inversion of the nipple. Bear in mind that some women have normally inverted nipple, so ask about the onset when you see inverted nipple. It may help to know that as a sign of breast cancer, it will be circumferential kind of inversion, while benign cosmetic inversion is usually slit inversion. Unlike retraction, nipple will get erected upon stimulation. Here's a picture of invasive carcinoma. We can see here redness and swelling. Here we can see pseudo-orange or pseudo-orange. It's a fixed opening, as we said, of the sweat glands. The coloring is helping to link it to orange. It's a very poor prognostic sign. Here we can see Paget disease of the nipple. We can see dark pink and itchy kind of nipple. It can be mistaken for eczema, but it shouldn't, because eczema will not make the nipple this pink and will not be this well delineated. Now, coming to investigations, we do have some modalities of screening. Self-breast examination, where you teach the patient to perform breast examination and you ask them to do that monthly, preferably following menses. Clinical breast examination is the same, but done by a health professional. Mammography, we'll talk about it later, and MRI is done for high-risk young individuals. Now, for mammography, we do have screening mammography and diagnostic mammography. Screening mammography is done for asymptomatic individuals. Technician will obtain 2 radiographs and then review them later. Diagnostic mammography is done for symptomatic individuals. It's a real-time mammography. So if the technician saw any abnormality, they will ask the patient or they will move the breast to have better access and better visualization. Abnormalities include mass that is poorly defined, and microcalcifications, architectural distortions, and interval mammographic changes. Bear in mind that calcification on mammogram doesn't mean cancer. Some diseases, such as fat necrosis and sclerosing adenosis, will appear as calcification on mammogram. Screening starts at the age of 40 for asymptomatic females and at the age of 30 for high-risk females. Bear in mind that you never do mammography before the age of 25. It has some limitations before the age of 35 because for young females, most of the breast is composed of dense breast tissues, and as they get older, which is not good media for mammography, as females get older, they have this dense fibrous breast tissue replaced with fat, which is excellent media for visualization on mammography. The test or the screening is repeated annually or every 3 years according to the guidelines you're following. Biopsy, we do have fine needle aspiration, which is not done as common as before, and core needle biopsy. As a general rule, if you're suspecting benign lesion, go for fine needle aspiration. If you're suspecting malignant lesion, go for core needle biopsy. Open or surgical biopsy is preserved for masses that are posterior and not within reach. Sentinel lymph node biopsy is very important for staging. So sentinel lymph node is the hypothetical first lymph node or group of lymph nodes to drain cancer. If you did not have cancer on sentinel lymph node, and you can know sentinel lymph node by injecting dye into the cancer and observing what is the first lymph node to absorb that dye. If you did not have cancer on the sentinel lymph node, there's a very unlikely chance to have metastasis anywhere. So it may help to remember that 75% of the lymphatic drainage is into axillary lymph nodes, and as we said before, the most common site for breast cancer is the upper outer quadrant, including the axillary tail. Most common site for metastasis is bone. Other investigations include ultrasonography, which is done for females before the age of 35. preferred over mammography, and it's done when there is pain to guide and to differentiate solid from cystic masses. Blood tests, complete blood count, liver function test, and serum calcium level are done to assess progression and response and metastasis. Serum cancer antigen 15-3 is important to check for response to treatment and to check for recurrence. Bone scan, as we said before, most common site of metastasis is bone, so it's important to check for bone scan. Computed tomography or CT is done bilateral to check and to check for metastasis. MRI, as we said before, it's important as screening tool for young high-risk individuals. It's done pre-operatively and has same indications as CT. BRCA mutation testing must be considered if you have more than 2 first-degree relatives, or if you have a young patient less than 50 years old, and or less than 50 years old, and if you have a male patient with breast cancer. Now, coming to staging, we stage according to the American Joint Committee on Cancer, TNM staging, tumor size, nodular or lymph node involvement, and metastasis. Stage 0, carcinoma in situ, early form, the cancer has not invaded the basement membrane yet. Stage 1 is localized, no lymph node involvement. Stage 2 is early locally advanced, with or without lymph node involvement. Stage 3 is late locally advanced with lymph node involvement. And stage 4 is metastasized disease. Important for my prognosis, staging is important for prognosis, and the most important thing is metastasis, especially to the axillary lymph node. Now, staging here in more details, we do have stage 1, less than 2 centimeters inside, no lymph node involvement, and of course no metastasis. Stage 2, between 2 to 5 centimeters, with or without lymph node involvement, and of course no metastasis. Stage 3, we have more than centimeter in size, we have lymph node involvement, and we don't have metastasis. For stage 4, we don't look at the tumor size, we don't check a lymph node involvement. As long as there's metastasis, it's stage 4 disease. Now, coming to management or treatment, we do have some modalities: surgery, radiation, chemotherapy, hormone-blocking therapy, and monoclonal antibody, treatment of complications, and follow-up. We'll start with surgery. We do have breast-conserving surgery, like lumpectomy, wide excision, or partial mastectomy, where you remove the tumor and somewhat larger amount of the surrounding normal tissue. And we have quadrectomy, where you remove 1/4 of the breast. We do have some types of mastectomy, the whole removal of the whole breast. We can do total mastectomy, modified radical mastectomy, where you remove the whole breast and the lining of the chest wall with or without the lymph nodes. And we do have radical mastectomy, which is rarely done now, unless you have chest wall involvement, where you remove the whole breast and you remove the chest wall muscles and the lymph nodes. Our surgeons may use or may do later breast reconstruction surgeries. Radiation, usually following or used as adjuvant therapy, may be used as neoadjuvant therapy, more effective during G2 phase, and decrease the recurrence by 70%. Chemotherapy, you do it before as neoadjuvant therapy to shrink the size and limit the need for total mastectomy. Now, hormone-blocking therapy used in estrogen receptor positive and progesterone receptor positive. We do have tamoxifen, which is a selective estrogen receptor modulator. It binds with the estrogen receptor and then inhibits the growth of the breast tissue. It may decrease the risk of osteoporosis and fracture. As a side effect, it increases the risk of DVT or deep vein thrombosis and pulmonary embolism, increase the risk of endometrial cancer. And aromatase inhibitors, examples are anastrozole and exemestane. They work by inhibiting aromatase, which is an enzyme that converts hormone to estrogen, and then reduce the production of estrogen. In postmenopausal women, aromatase inhibitor may be preferred or may be more beneficial than tamoxifen. They increase the risk, as a side effect, they increase the risk of osteoporosis, and both tamoxifen and aromatase inhibitor will increase or will worsen postmenopausal symptoms. Now, for monoclonal antibody, they enhance the immune system ability to fight cancer. One important example is trastuzumab, which is used with chemotherapy to treat metastasis or metastatic breast cancer when the breast cancer is HER2 positive. It prevents multiplying of the breast cancer, and is therefore useful. For treatment of complications, we have bisphosphonate for bone metastasis and low molecular weight heparin to reduce systemic venous thrombosis. For follow-up, we do physical examination every 3 months for 2 years, and then every 6 months for 5 years from the date of cancer diagnosis. Regular mammograms and breast self-examination are also important. So treatment is decided based on location of the primary tumor, lymph node involvement, and expression of hormone receptor or HER2 receptors. Here's the treatment by decided by stage. So for stages 0, 1, and 2, we will do breast conserving surgery and radiotherapy, and we may add axillary node dissection. For stages 1 and 2, we may consider, if appropriate, adjuvant therapy such as chemotherapy and hormone therapy. For stages 3 and inflammatory carcinoma, we may benefit now from new adjuvant therapy before the surgery to shrink the size and therefore limit the need for total mastectomy, but most likely you will need to do total mastectomy, axillary node dissection, and radiotherapy. For stage 3, you will consider adjuvant radiation and chemotherapy following the surgery. For stage 4 metastatic disease, surgery is not the main modality of treatment. You may consider it now to achieve local control if appropriate, and you will depend on chemotherapy, radiotherapy, and hormone therapy as main modalities of treatment. Prognosis of breast cancer is generally good. It can be up to 98 to 110 to 100% for stages 0 and 1, and it can drop to 16% for stage 4 or metastatic disease. So coming back to TNM, tumor size, nodular involvement, metastasis. Metastasis will be the most important thing to determine the prognosis or survival rate. But given that metastasis is not common presentation, you will go for a nodular involvement as the most useful factor to determine prognosis. Remember, sites for metastasis, most common site for metastasis is bone, followed by lung, followed by pleura, followed by liver, and then the brain. We have a case here, a 40-year-old female presented to you with palpable breast lump that she detected while showering. She denies any nipple discharge, bone pain, or abnormality in breast appearance. Now, what would you ask her? What are you most concerned about? Of course, breast cancer. What risk factors should be questioned in this patient? family history, early menarche, radiation, and alcohol consumption. We didn't mention that before, but alcohol consumption, even moderate alcohol consumption, can be a risk factor for breast cancer. What physical findings may suggest breast cancer? Dimpling of the skin changes, nipple retraction or inversion, axillary mass, bone pain, but she denied bone pain. What test should you order next in this patient? Diagnostic mammography. How is the diagnosis confirmed? Biopsy. Um, the treatment will depend on the stage. So for stages 1 and 2, you will do breast conserving surgery and sentinel lymph node biopsy. And radiation, you may do axillary dissection or lymph node dissection. For stage 3, you will do neoadjuvant chemotherapy and radiation, and then followed by mastectomy, if appropriate, followed by adjuvant therapy, chemo or hormonal therapy. And for stage 4, you will do chemotherapy, hormonal or hormone therapy, and you may consider surgery and radiotherapy. By this I reached the end of my presentation. Here are my references. Thank you for watching. If you have any questions or comments, please send them to the email shown here. Enjoy a nice day.